Good afternoon, everyone, and welcome to today's webinar, The Basics of HIPAA Standards and Operating Rule Adoption. I want to thank Beth Karpiak and Michael Cimino from the CMS National Standards Group for joining us today, and they'll be providing the bulk of the presentation. Erin will introduce them in just a few minutes. But before we do that, I want to discuss just some quick logistics for today's webinar. So looking at the next slide, you can go ahead and download the presentation slides from that handout section of your GoToWebinar menu if you want to have a copy on hand. We'll also send out an email to all attendees and registrants in the next 1 to 2 business days with information on how to access those slides, as well as a link to today's recording. If you have a question throughout the presentation, please feel free to submit it at any time. You can do so using that questions panel on your GoToWebinar menu. We'll be monitoring questions and should have a few minutes at the end to have a discussion and ask those to our speakers for today. Before I go into our agenda, we do just want to highlight our CAQH Connect conference that's taking place in September. It's the 27th to the 29th. It'll be in Washington, D.C. We're really excited to bring together healthcare leaders, experts, executives from across the nation. And if you're able to join us, you can actually go ahead and take a picture of that QR code on your phone if you have it handy, and that will take you right to the registration page. It's also linked on this slide if you go ahead and download those slides after the presentation. Taking a look, taking a look at our agenda. First, we're going to kick things off with a very brief core operating rule update. You'll hear from Erin. And then she's going to pass it over to Beth and Michael from CMS's National Standards Group. And they're, like I said, they'll be doing the bulk of the presentation today discussing HIPAA standard transactions. At the end, we'll have time for questions. And with that, I'll pass things over to Erin Weber.
Great, thank you, Jackie. I just want to take a second and thank Michael and Beth for joining us today and give you all a little bit more information about their background. I'm Erin Weber. I'm the Vice President of Core and lead a lot of our day-to-day efforts here with our operating rules. Michael Cimino is Director of CMS's National Standards Group within the Office of Burden Reduction and Health Information. Prior to this role, Michael served as the Deputy Director for the Division of Quality and Compliance within the Provider Enrollment and Oversight Group in the Center for Program Integrity at CMS, and as the Deputy Director for the Division of Enrollment Operations, also within CPI. Michael has spent the past 10 years working on a variety of initiatives in Medicare and Medicaid at both the federal and state level. And Beth Karpiak is a policy advisor with the National Standards Group. Prior to joining NSG, Beth managed a team within the CMS Survey and Operations Group that imposed a variety of enforcement remedies against healthcare providers to ensure prompt and continued compliance with quality standards. Before joining CMS, Beth was a staff attorney and equal justice work fellow at the Illinois Protection and Advocacy Agency. We are so grateful that you both are able to join us today. I will note that I saw a version of this presentation at HIMSS earlier this year and thought it was a really helpful overview of the work that your team does. So I'm glad we have the opportunity to share it with a broader audience today. Before I turn it over to Michael and Beth, I'm going to give a quick update, operating rule update for those who are new to Core. We are the Committee on Operating Rules for Information Exchange. We are a consensus-driven collaboration of about 100 organizations across the healthcare industry that come together to develop operating rules, which are really business rules that help the industry create more automation and improve the use of standards. We are designated by the Secretary of HHS as the National Operating Rule Author and have been since 2012. We have 8 sets of operating rules available now, several of which are federally mandated, others of which are available for voluntary implementation. On the next slide, some good news for those who are following the work that we do. You may recall that last year, the Core Board sent a letter to the National Committee on Vital and Health Statistics, which is the federal advisory body to HHS on topics related to administrative simplification, as well as privacy and security and population health. And I know Beth and Michael will touch on that in a little bit more on NCVHS in a minute. But our board proposed a new set of operating rules for federal adoption, as well as some updates to some of the existing federally mandated rules. Over the past year, NCVHS has collected feedback through a request for comment. They held an industry hearing earlier this year to review and solicit feedback from the industry on those proposed operating rules. And just at the end of last month, NCVHS did send a letter to HHS recommending a set of proposed operating rules for adoption under HIPAA. And if we go to the next slide, we outline the recommendation from NCVHS. So they are proposing that HHS adopt updates to the 3 federally mandated core infrastructure rules for eligibility and benefits, claim status, and the payment and remittance advice transaction. These rules adopt updated versions of core connectivity, as well as improved system availability requirements across the industry. Building on that, NCVHS also recommended an updated version of the core connectivity rule. The current versions that are federally mandated were developed more than 10 years ago now. So this is a really critical update to ensure that we have REST protocols available and higher levels of security and authentication across the industry. NCVHS also recommended an updated eligibility and benefits data content rule, which includes health plans to convey requirements around prior authorization, tiered benefits, and other really critical topics like telehealth in that eligibility transaction. Coming out of our value-based payment efforts over the last couple of years, the single patient attribution data content rule, which requires plans to indicate whether or not a patient is attributed to a given provider in the eligibility transaction, was also recommended to HHS. NCVHS did not recommend the core attachments operating rules for prior authorization and claims. For those of you who have been following the policy world closely, you'll know that CMS put out 2 proposed rules back in December related to standards for prior authorization and attachments. And those rules aren't finalized yet. So NCVHS didn't feel comfortable proposing operating rules before a standard. And finally, and this is consistent with all the recommendations and rules that have been adopted to date, NCVHS clarified that the core certification requirements should not be included in the proposed rule ranking process. That is a voluntary effort. So I'm going to turn it over now to Michael and Beth, who will talk a little bit about what happens after they receive an NCVHS recommendation, whether for operating rules or standards, and more broadly about the work that they do under the HIPAA administrative simplification provisions. Beth and Michael?
Yeah, thank you, Erin. So I just want to, when we will talk about that process, I think you'll see that kind of woven throughout here. I just want to thank everyone for attending today, and thank you to CORE for inviting us to present. We can go to the next slide. So our goals today are to talk about the processes that govern our work and how the industry is designed to play a role in those processes. And we'll start with what HIPAA administrative simplification is, how HIPAA transaction standards fit in with general healthcare interoperability concepts, and then we'll talk about how transaction standards and operating rules are adopted under HIPAA and the regulatory processes that are involved in those actions, as well as processes for adopting modifications to standards and operating rules, which can be slightly different. And then finally, we will close with a few considerations for the industry to support HIPAA adoption of newly emerging standards and operating rules. Next slide. So with that in mind, the objectives for today will be able to identify requirements for adopting transaction standards under HIPAA, learning to distinguish requirements to adopt standards or operating rules under HIPAA from the standards and operating rule development process, and being able to being able to outline the requirements for testing under HIPAA, Testing, as we'll talk about in a little bit here, is really key to ensuring that any newly developed standards or modifications are going to meet the needs of the industry, as well as create a positive ROI for the industry. Next slide. So to start out, we'll talk about what is administrative simplification. And I'm going to trip up at some point having to say that out. Usually we say admin simp. So, and this is going to be somewhat general as we discuss the overall concept and the goal of admin simp. So the vision or the idea behind HIPAA administrative simplification is that the healthcare industry can reduce burden and lower costs by standardizing how business is done. And what that means is when electronic administrative tasks between players in the healthcare industry, so we talk about providers, plans, clearinghouses, and their business associates, are conducted the same way, regardless of what player an entity is engaging with, the industry can then automate many of their billing and payment processes. And I think we all know that's going to reduce time spent on those administrative tasks, which in turn will save healthcare dollars. So that's more of the big picture, and we'll talk a little bit about the actual 1996 legislation, right? HIPAA, which was codified in the Social Security Act, and it creates a role for the federal government in promoting administrative simplification so that the benefits of standardization can be realized industry-wide. And it does this by tasking the Secretary of the Department of Health and Human Services with adopting standards that all covered entities must follow by law. The law also includes safeguards that prevent, for example, one entity using their leverage to dictate and use standards that may only meet their needs or may be too costly to benefit other entities in the industry. Next slide. So administrative simplification requirements under HIPAA typically fall into two categories. The first represents requirements related to how administrative electronic healthcare transactions must be conducted. And the second relates to requirements related to security and privacy protections that entities that conduct the transactions must put in place to safeguard patient information. The National Standards Group, or NSG, within CMS, within CMS's Office of Burden Reduction and Health Informatics, or OBRI, administers the first category that I mentioned, right? Those administrative healthcare transactions such as claims and payment of claims. When we think about the provisions related to privacy and security, which I think most people, it comes to mind for most people, right, when they hear HIPAA, those have actually been delegated to the HHS Office for Civil Rights. So what does this mean for NSG? It means that NSG is responsible for a few things. The first is adopting standards, meaning that NSG is publishing in regulation the standards that the industry must follow when they're conducting electronic healthcare transactions. And the second is that NSG is administering those standards amongst covered entities, meaning that NSG is enforcing and ensuring the industry is compliant with the standards. So we provide guidance that speaks to the requirements in certain scenarios, and we manage an enforcement program that seeks to resolve complaints of non-compliance. We also conduct compliance reviews of covered entities to that end. And so we should, I think we should clarify something just briefly about NSG's location in CMS, because typically I think when folks think of CMS, the first two things that come to mind are Medicare and Medicaid. And the requirements to obviously receive payment under those programs. However, NSG was delegated authority by the law on behalf of the Secretary of HHS. So this provides NSG the authority to enforce our HIPAA requirements across all covered entities, so all health plans, clearinghouses, and covered providers, regardless of their Medicare and Medicaid affiliation, and actually includes Medicare and Medicaid as health plans. So we're in a unique position there. Just wanted to call that out. Next slide, please. So we've talked about NSG's role as it relates to administrative healthcare transactions, but I want to go into more detail about exactly which transactions are within our purview. And you'll see the list on this slide of the transactions that are actually defined in statute as being within our purview. For example, you see referral, certification, and authorization. Typically, this is referred to as prior auth. Not shown on the slide, NSG is also tasked with establishing standards to support the coordination of benefits, activities, and electronic signatures. I want to point out for this list of transactions that the statute doesn't define what these transactions are or what they mean. So when we adopt standards, we also adopt definitions for each of these transactions. And some of these may seem fairly obvious, but there can be a lot of nuance and important detail that comes into play in those definitions. And so one example would be a claim is defined as a transmission of information from a provider to a health plan. So we think of the example of a state Medicaid agency contracting with a managed care organization. And the MCO provider submits an encounter claim, right? The first transaction on our list there to the MCO. This is a HIPAA standard transaction. But when the MCO submits a bill to the state Medicaid agency for payment, this transaction does not meet the definition of a healthcare claim or encounter information because it's not being transmitted between a provider and a plan. HIPAA has no authority over the transaction between the plan and the state Medicaid agency, which is also a health plan. Another example to think about here is prior auth. So for the purposes of HIPAA standards, prior auth is defined as only the transmission of a request from a healthcare provider to a health plan to obtain an authorization for healthcare or the referral and the transmission of a response from the health plan to the healthcare provider to approve that request. So standards adopted under HIPAA only apply to a narrow portion of the prior auth process, that portion of the request transmitted from the provider to the plan and from the plan back to the provider. For example, how a provider determines whether prior auth is required for an item or service, that would not fall within the HIPAA definition of prior auth. So in addition to these transactions that are named in statute, there's also a catch-all for other financial administrative transactions determined to be appropriate, under which NSG has defined and adopted standards for health plan premium payments and Medicaid pharmacy subrogation transactions. Next slide. So looking at our timeline here, in order to talk about where we're going in the future and to talk about testing and modification of adopted HIPAA standards, it's important to understand some of the history. And I mentioned at the beginning that we'd talk a little about the 1996 legislation. So it was in 96 that HIPAA was passed. And then it was in the year 2000 that NSG published a rule that adopted initial standards for several healthcare transactions. And then in 2010, the ACA was passed, which created the requirement to adopt operating rules for each transaction for which there is a standard. So standards dictate the format and the content of the electronic transmission for a healthcare transaction, while the operating rule sets the business rules and guidelines for the electronic exchange of information that are not defined by an implementation specification. So an operating rule is something separate and in addition to the standard. And then towards the end of that timeline there in 2011 and 2012, NSG, in accordance with the ACA, adopted the first set of operating rules. Next slide. So we have transaction standards and we have operating rules for transactions. When you combine those two concepts with a transaction that complies with standards and operating rules, you have the HIPAA standard transaction. And there are actually 4 items that a transaction must comply with. The first are the adopted implementation guides. These are often referred to as the standards. The implementation guides set the data content and the format requirements for the information that is being transmitted. So currently we've adopted X12 and the NCPDP implementation guides, and you've probably heard the X12 guides referred to as the TR3 reports. And just to clarify, in other sectors in the industry, standards might mean something else, but in the HIPAA transaction world, standard means an implementation guide. And so the second of those 4 items are adopted unique identifiers. So under HIPAA, the Secretary adopted unique identifiers that must be used with transactions to identify healthcare providers, called the MPI. And for employers, we call the EIN. So covered healthcare providers are required to obtain the MPI, and covered entities must use that MPI and EIN on all standard transactions that require the provider or employer identifier. And then the third item a transaction must comply with are code sets. Some code sets are specified within the implementation guides, while some are adopted in regulations such as medical code sets. And then finally, the 4th item on that list is compliance with the adopted operating rules, which again, the operating rules set the business rules and the guidelines for electronic exchange of information that aren't defined in the implementation guide. For example, we've adopted an implementation guide that sets the data content and the format requirements of an eligibility transaction for a health plan, while there's an operating rule that governs system availability for those transactions. So this is one example of a business process that's not in the implementation guide, but is required under an adopted operating rule. So just to summarize, when we talk about a HIPAA standard transaction, we're referring to a transaction that complies with all 4 of those areas. Next slide. Okay, so now that we've talked about what a HIPAA standard transaction is, I want to talk about the regulatory provisions that ensure all covered entities are consistently conducting HIPAA standard transactions. And again, it ensures that the industry can realize the benefits of standardization, which we talked about at the beginning. Also, these are not all of the requirements that we enforce, but probably easily the 3 most important. And so the first is called the general rule, and that's the actual name at 162.925A. So the general rule says that when a covered entity conducts a transaction for which a standard has been adopted with another covered entity using electronic media, the covered entity must conduct the transaction as a standard transaction. So what does that mean? So anytime a covered entity is electronically transmitting information that meets the definition of a transaction for which the Secretary has adopted a standard, the entity must conduct that transaction so that it conforms with the 4 items we talked about on the previous slide. The implementation guide, the code sets, the unique identifiers, and the operating rules. The next of the 3 is at 162.925A1, which requires a health plan to conduct a transaction as a standard transaction when requested to do so. So for example, if a health plan is choosing to send remittance advice to a provider on paper, should the provider request that the health plan conduct the RA transaction as an electronic transaction or HIPAA standard transaction, the health plan must comply with that request. And then the third point from 162.915, which is actually a prohibition, states that a covered entity is prohibited from entering into agreement that would change the definition, data condition, or use of a data element or segment in an adopted standard or operating rule. So for example, an implementation guide may say that a certain data element must be populated with a zip code using the USPS code set. Plans plans would not be able to ask a provider, even if the provider agrees, to put some plan-specific 4-digit ID instead of the zip code in the spaces that are reserved for the last 4 digits of the zip code. This would be changing that definition of the data element, which is prohibited by this particular section. And next slide. So moving on from the background portion to discuss how HIPAA standards and the process of adopting HIPAA standards interact with or align with general principles of healthcare interoperability. So outside of HIPAA and administrative transactions, the healthcare industry is always looking to processes and standards that make the exchange of health information seamless. And obviously standardizing data, right, and how we communicate that data plays a big role in making that possible. Next slide. So just a graphic. Historically, interoperability and the work done to promote healthcare interoperability has been largely in the clinical space, and it typically speaks to clinical health information, whereas HIPAA transactions really fit squarely into the administrative space. So this graphic here is really just to illustrate, I guess, that division between the clinical provider versus someone who's working on administrative tasks, and there's no real overlap between the two. But we all know the clinical world and the administrative world, they do overlap, and they need that overlap to achieve true healthcare interoperability. So neither space can operate in a vacuum. Administrative decisions for certain transactions are based on clinical health information. We know that. So moving away from that divided approach and into something that's more integrated. Next slide. And so an example of this clinical administrative overlap is with the prior auth transaction. In order to do a start to finish prior auth transaction, there's a need for administrative data such as the information about the requester and the subscriber's health insurance coverage. And then the clinical information also needs to be transmitted, since the health plan needs health information to determine if the requested services are clinically appropriate. In the past, standards for clinical data have been separate from standards for transmitting administrative data, but they must be compatible in order to support true interoperability. And while HIPAA standards govern the format and the data content for the transmission of the request, HIPAA does not govern all of the information sharing that has to take place before the transmission of the request and prior to the response during the health plan's decision-making process. So any standards that are being developed and implemented to streamline the prior auth process outside of the transmission of information should support or work with the HIPAA standards that are adopted for the transmission of the information, but they don't necessarily have to be the same. As standards and methods are being developed for processes outside of the transmission that don't work with the currently adopted standards, there is a process built into the statute to support adoption of new or modified standards. So as clinical information standards and technologies advance, should new standards arise that serve the same functions or business purposes as adopted HIPAA transaction standards, but are more efficient, streamlined, and less costly, then the industry and the secretary can move to adopt those new or modified standards. So that's really a quick overrun of rundown of process for adopting standards and operating rules, which is largely driven by the standards development community and the industry, again, including plans, providers, clearinghouses. And I'm going to hand things over next to Beth Karpiak, our policy advisor.
Thanks, Michael. So I'm going to be talking about that standards adoption process, so standards and operating rules. And I'm starting here on this slide with the standards. And I've broken down the standards adoption process into 3 main phases. I have a high-level description of each phase here, and then on this slide, and then I have additional slides to go into a little bit more detail on each phase. So first, standards need to be developed. With a few exceptions, any standard adopted under HIPAA must be developed by a standard setting organization, or an SSO, which is an organization accredited by the American National Standards Institute, or ANSI, that develops standards for information transactions, data elements, or other standard that's necessary to or will facilitate the implementation of HIPAA administrative healthcare transactions. So that's the development by an SSO. The second phase involves the National Committee on Vital and Health Statistics, or NCVHS. And so under the statute, the secretary must, and I'm emphasizing must, exact quote from the statute, rely on the recommendations of NCVHS when adopting HIPAA transaction standards. This doesn't mean that the secretary must agree with all NCVHS recommendations, or act immediately upon every NCVHS recommendation, but it does mean that the recommendations for adoption must go through NCVHS before the secretary considers adoption, and that we must rely on those recommendations from NCVHS. And then the third phase is the regulation development phase. So after NCVHS has made a recommendation and NSG moves to the recommended standard on behalf of the secretary, we must go through the Federal Register in a rulemaking process. And Aaron mentioned earlier, in the context of updated operating rules, that's where we are. We have this new recommendation, and now we are required to go through that rulemaking process. Next slide, please. So I already mentioned that any standard the secretary considers for adoption under HIPAA must be developed by that SSO, the standard setting organization. On top of that, NSG has promulgated regulations that established organizations called Designated Standards Maintenance Organizations, or DSMOs. DSMOs are designated by the secretary through notice in the Federal Register and agree to maintain standards adopted under HIPAA. And they also agree to receive and process requests for adopting standards. As of right now, the designated DSMOs are the ADA, the American Dental Association, the Accredited Standards Committee, X12, Health Level 7, the National Council for Prescription Drug Programs, or NCPDP, the National Uniform Billing Committee, and the National Uniform Claim Committee. And I always get this backwards, so I'm going to speak very, very slowly. All DSMOs are SSOs, so all designated standard maintenance organizations are standard setting organizations accredited by ANSI, but not necessarily all standard setting organizations are DSMOs. So that second piece of the DSMO role regarding receiving and processing requests for adopting standards is where I'll focus the rest of my words on DSMOs. So the secretary established requirements for that process of the DSMOs receiving and processing requests, which I have on this slide. So once a DSMO receives a recommendation from an SSO, again, that might be the same entity. A DSMO could also be an SSO. But once they receive that recommendation, the secretary will consider the recommendation if it's developed through a process that provides for one, open and public access, also coordination with other DSMOs. So if it's an SSO proposing the recommendation and they're also a DSMO, before recommending to NCVHS, the secretary would expect that there would be consultation and coordination with other DSMOs on the recommendation, because we have this regulatory requirement that will consider the recommendation if there's been this consultation and coordination with the other designated standard maintenance organizations. There also has to be an appeals process if the requester or the DSMO is dissatisfied with the decision on the recommendation, an expedited process to address content needs identified within the industry, and then finally submission of the recommendation to NCVHS. So moving from the recommendation from an SSO through consultation with the DSMO as described in this regulation, and then finally submission of the recommendation to NCVHS. So next slide, please. So should that standards development and recommendation development process through the SSOs and DSMOs result in the organizations believing the standard should be adopted under HIPAA, they'll make that recommendation to NCVHS. NCVHS is a federal advisory committee identified in statute and also called a FACA, so Federal Advisory Committee. When in receipt of a recommendation, the NCVHS Subcommittee on Standards holds public hearings with the industry to gather feedback on how the industry would be impacted by adoption of the standard. So because the Secretary is charged with adopting standards that, and I'm quoting here from the Social Security Act, so standards that reduce the administrative costs of providing and paying for healthcare and that reduce clerical burden. Part of what NCVHS's role is to gather information from the industry that would help the Secretary assess whether the recommendation would indeed reduce costs and reduce that clerical burden. Next slide, please. So should NCVHS make a recommendation that the Secretary adopt a standard and the Secretary agrees with or accepts that recommendation, NSG then begins the rulemaking process. The first step is publishing a proposed rule, often called a Notice of Proposed Rulemaking or NPRM in the Federal Register. In addition to including the proposed regulation text, the proposed rule is also going to explain why the Secretary is proposing the standard. And part of that why is a regulatory impact analysis. So NSG must assess all the costs and benefits of the proposed standards and also any available regulatory alternatives and select the regulatory approach that maximizes benefits. So in the previous slide, I talked about those statutory charges to adopt regulations that reduce costs and burden. We also have these procedural processes that are part of the rulemaking process that aim to ensure that the benefits of any regulatory act taken are going to outweigh its costs. So we're kind of doubled up on that cost benefit here. We've got the HIPAA requirement to generally adopt standards that are going to reduce burden, and then also just going through rulemaking, the Administrative Procedure Act and other executive orders requiring us to ensure that the regulatory action we take, that the costs are, the benefits are going to outweigh the costs. So after an NPRM rule is published, there's a comment period, typically 60 days. NSG reviews those comments, and then should the Secretary decide to issue a final rule, that will include final regulatory text along with any responses to those comments. For adoption of a new standard, meaning the standard is not a modification to a currently adopted standard, it might be a totally new standard for an existing transaction or a totally new transaction for which the Secretary is adopting a standard. All covered entities, with the exception of small health plans, must comply with that new standard 24 months after the date it is adopted, and small health plans are given an additional 12 months, so 36 months to comply. Next slide, please. So moving on to an overview of the process for adopting operating rules. Last few slides, we're talking about standards only, and the process for adopting operating rules mirrors that pretty closely, but there are some slight differences. So as this slide shows, there's the same 3 high-level steps. There's rule development, but instead of an SSO, operating rules must be developed by a qualified nonprofit entity, such as CAQH. And we'll go through what makes an entity qualified and some statutory parameters on how they must develop operating rules in the next few slides. Just like standards, the Secretary is still required to rely on a recommendation from NCVHS when we're adopting operating rules. But there's a few more things that NCVHS is charged with when considering a recommendation for an operating rule. So we'll go over those. And then finally, step 3, just like standards, rulemaking is required to adopt an operating rule. So we'll go to the next slide. So back to that step 1, how must operating rules be developed? So they must be developed by an entity that demonstrates a multi-stakeholder and consensus-based process. So this ensures that operating rules that are considered for adoption under HIPAA are developed with input from the spectrum of the industry. So plans, providers, vendors, federal agencies, and standards development organizations. The process must also be open and transparent and allow for public review and updates to the operating rules. And I'll note that operating rule development is only necessary to the extent that business rules are not included in the standards. the implementation specifications that Michael discussed that have been adopted for transaction, because recall by definition that operating rules are the business rules and guidelines for electronic exchange of information that are not included in the implementation guide. So the operating rule by nature, by definition, is something that's above and beyond or outside of the implementation specification. Next slide, please. So back to authoring, operating rule authoring entities. The statute specifies all the processes a qualified entity must have in place. We went through those on the last slide, but how does NSG know who qualifies as an authoring entity? Well, the statute has an answer for that, and it's NCVHS, so another one of their roles here with operating rules. They're charged with advising the secretary as to whether or not an entity has the processes in place to meet the requirements to be considered a HIPAA operating rule authoring entity. And currently there is only one operating rule authoring entity, and that's our host today, the Council for Affordable Quality Healthcare Committee on Operating Rules for Exchange, or CAQH Core. So should CAQH Core recommend a rule for HIPAA adoption, NCVHS is charged with reviewing that recommendation. And when doing so, they're looking to see if the rules are consistent with the standards adopted under HIPAA, so they have to be able to go together, work together, and determine whether such rules represent a consensus view of healthcare stakeholders. And I'll emphasize again, consensus view, because that is a direct quote from the statute. So when it comes to operating rules, NCVHS is explicitly charged with determining whether there's industry consensus on the rules when they're making a recommendation to the secretary for adoption. A few things, additional things I'll note here. And Aaron, you alluded to this regarding the attachments operating rules. So the secretary does not have authority to adopt operating rules for a transaction that does not have an adopted standard. So the secretary is required to adopt operating rules for, and this is a quote, any transaction for which a standard has been adopted. New operating rules, so if it's not a modification to an existing one, but a new one, maybe for a new standard, for a new transaction, there's a statutory provision that they should be adopted by interim final rule with a 60-day comment period. So that eliminates that proposed rule, that NPRM, potentially when we are presented with a recommendation to adopt a new operating rule. Compliance dates are also slightly different for operating rules than for transactions, than for standards. So compliance dates of new operating rules for those listed transactions that Michael had on an earlier slide, there's specific dates in statute, and some of those dates have passed. And so we're looking at a situation where we cannot fulfill that statutory mandate, so there could be some discretion there in terms of operating rules for those new operating rules. And then next slide, please. So we've talked about the process for adopting operating new standards and new operating rules. I'm now going to talk about changes to what we've adopted. So once standards and operating rules are adopted in regulation, of course, the world around us doesn't remain static. We cannot expect standards to accommodate industry needs indefinitely. Technology changes, business needs changes, business needs change, expectations change. So the statute and regs include processes to accommodate changes and updates to the adopted standards and operating rules. I've categorized 3 types of changes: 2 that don't require regulatory action and 1 that does. The first is code set maintenance, which is one that does not require regulatory action. So organizations responsible for maintaining code sets internally conduct routine maintenance, testing, and expansion activities. And as such, once adopted under HIPAA directly in reg or incorporated into an implementation guide, deletion and addition of codes do not trigger the need for rulemaking to adopt those new codes within the set. The second type of change is errata or standards maintenance. Should an implementation guide or an operating rule include a typo or other non-substantive error that's identified after adoption? Regulatory action is not required to include that non-substantive error correction in the adopted version. And then finally, there's substantive changes to standards and operating rules, and those must be adopted through regulatory action, following several of the same processes that are reviewed for adoption of initial standards and new operating rules. Next slide, please. So the process for adoption of modification to standards follows the same 3 high-level steps: development, NCVHS, and rulemaking. But there is a few caveats. So the Secretary may not adopt any modification to a standard adopted under HIPAA during the 12-month period beginning on the date the standard is initially adopted, unless the Secretary determined that the modification is necessary in order to permit compliance with the standard. So there is kind of a pump the brakes. So we can adopt that new standard, but any modification shouldn't be adopted within the 12 months after the new standard's adopted. And then further compliance dates for a modification differ from those for adoption of an initial standard. So we talked about 24 months and 36 for small health plans, but for a modification, covered entities must comply with a modified standard at such time as the Secretary determines appropriate, taking into account the time needed to comply due to the nature and extent of the modification. So the time determined appropriate may not be earlier than the last day of a 180-day period beginning on the date such modification is adopted. So at least 180 days for compliance dates for modification to standards. But after that, really discretionary versus for a new standard, pretty straightforward for the 24 and 36 months in the statute. Next slide, please. So similarly with modifications to adopted operating rules, there's some high-level processes to adopt substantive modifications, the same high-level processes to adopt substantive modifications as there are to adopt an initial or new operating rule. Again, development, NCVHS, rulemaking. A change, however, is with the compliance dates for a new operating rule versus a modified operating rule. The compliance date for any amendment to an existing operating rule is 25 months. And that was part of the Affordable Care Act and is explicit in the statute. So for modifications to adopted standards, the Secretary has discretion for compliance dates as long as it's more than 180 days. But with modifications to existing operating rules, those compliance dates will be exactly 25 months from the date of adoption. Next slide, please. So moving on to the exceptions process, and we'll go through this quickly so that we have some time for questions. So for the Secretary to adopt substantive modifications, the modification has to be an improvement over the existing standard. So should a recommendation for a modification be proposed to NCVHS, it should only be recommended to the Secretary if the modification is going to benefit the industry, reduce costs, reduce burden, as compared to what's already in place. So being able to demonstrate with any sort of accuracy what costs will be to implement a proposed modification and what benefits it could bring is a considerable task, especially when under HIPAA, covered entities cannot just unilaterally choose to try something else. They have to use the adopted standard. So trying something else, if there's a standard in place, would be a regulatory violation. So to facilitate this type of testing and data gathering that the industry and the Secretary need in order to adopt a modification, NSG established through regulations an exceptions process by which a covered entity can request an exception from the Secretary to test a proposed modification. And if granted an exception, the approved entities will not be at risk of violating requirements of the existing adopted standards. And a note, we have a guidance letter that I've linked in the slides here on our website about the logistics of how one would go about requesting an exception to test a modification. Next slide, please. So the exception process has 3 main parts: request, test, and then report. The request piece is pretty straightforward. The requester must provide a detailed explanation of how the proposed modification would be a significant improvement to the current standard. Within that request, there must be a testing plan, so that's the test piece. And then finally, within 90 days of completing the test, the organization must submit a report on the results of the test that includes a cost-benefit analysis. Next slide, please. And so within the regulations that we developed to control the exception process, we included these 10 principles. So they're generally 10 principles that an exception request has to demonstrate. And I think it can be looked at kind of generally to apply to any type of modification. And so generally they focus on ensuring that there's adequate information that the exception is going to, or at least anticipated to reduce cost and burden and benefit the industry. Next slide, please. So I'm at my sum it up point. So to sum up, pulling from Michael's piece of our presentation, HIPAA scope is relatively narrow. Standards adopted under HIPAA are implementation guides that must be used only for the specific transactions as they're defined in regulations. And to adopt and modify those standards and operating rules, the industry plays a huge role. But there are processes in place to ensure that all sectors are participating, and standards and operating rules and subsequent modifications are developed by standard setting organizations and operating rule authoring entities that take all these industry perspectives into consideration. And with those considerations in mind, I'll throw it back over to Michael to see if there's anything you wanted to chime in on before we open the floor for questions.
No, I think I'm good.
Great. Well, thank you both for that wealth of information. I know even though I live and breathe this on a daily basis, it's nice to see it so clearly laid out and understandable from kind of inception to adoption. So very much appreciate it. We got a number of great questions. I'm going to start with some questions we received through the registration process, and they were all related to the CMS enforcement process and compliance trends that you're seeing. And I know we didn't really cover it in this presentation, but another area of focus for your team at the National Standards Group is enforcement. Can you talk briefly about your work in that space and where folks can go to learn more?
I can start. Are you guys hearing feedback, or are we good?
Yeah, I was getting a little bit. I think we're good. Beth, I'll go ahead. I'll let you start on
Okay. Yeah, I love talking about the enforcement aspect of our work. Michael mentioned briefly, there's two prongs to our enforcement program. So we have a complaint management program. Anyone, covered entity or not, if you believe that a covered entity is in violation of one of our requirements or an adopted standard or operating rule, you can file a complaint through an online platform, and we'll work to investigate that noncompliance and resolve it to the Secretary's satisfaction. And then we're also doing compliance reviews, where we are randomly selecting covered entities and conducting kind of a full comprehensive review of all transactions that they conduct for compliance with our adopted standards and operating rules. In terms of where to learn more, please go to the Administrative Simplification website. If you're interested in the types of complaints that we receive or the volume of complaints we receive or what transactions we receive the most complaints about, we have quarterly complaint reports that will give high-level numbers, and there is some information about numbers based on transaction type. And we also have corresponding quarterly reports for our compliance review program that can tell you the types of violations we're seeing, and also some really helpful reports I like about some lessons learned and tips for the industry based on the most common violations that we identify during compliance reviews.
Great, thank you. Next question. Someone was curious about whether there are specific requirements or rules around when an agency uses an interim final rule versus an NPRM, and how is that determined?
So I think that depends on, well, in our case, right, we had explicit direction in statute regarding an interim final rule, but typically we'll go to NPRM. Beth, I don't know if there's anything you want to add on that.
Yeah, I'll just say we have that statutory directive, but there's also Administrative Procedure Act requirements related to rulemaking, and we rely heavily on our Office of General Counsel to advise us on that. But we do have those statutory requirements that Mark mentioned.
Great. Another question around, can you talk about the responsibility for a subcontractor under a government contract related to the standards required under HIPAA? Are there differences between contractor or subcontractor requirements in terms of compliance with HIPAA?
Well, I'll start briefly, and then I'll start generally, I guess, and then let Beth maybe talk to some of the details. But whether or not something's contracted out, I mean, the covered entity is still responsible for compliance with those requirements. I don't know if that's exactly what they're getting at, but Beth, anything you want to add maybe to that?
I'll just note that we did release, and I think this is what the question might be getting at, Aaron, a guidance letter that explains covered entities' responsibility to ensure that their business associates, so folks that they would contract out to conduct all or a portion of a transaction for which there's a HIPAA adopted standard, so to ensure their compliance, the business associates' compliance with the requirements. So we have a guidance letter on business associates where folks can find more information about that.
Perfect. Now for more of a philosophical question, but there's been a lot of recent industry discussion and an NCVHS as well as to how to ensure that HIPAA standards are in line with current industry technologies. So one example is prior authorization. You mentioned that the proposed rule that came out recently uses FHIR and includes an X12278 component as well to remain HIPAA compliant. How can we ensure HIPAA continues to support modernization over time?
I think a lot of that's going to come from the industry, right? What are the industry's needs? And I know that we love hearing from the industry. We're actually looking at ways on how we can increase that. How can we create more forums where we can hear from folks and get their feedback? But given the process, going to the organizations, and the feedback to NCVHS is really what's going to craft whatever that recommendation is that comes to us, that then allows us to move forward with adopting any of those standards.
Great. I think a question in a similar frame of reference is around the exemptions process, and how can the exemption process be used around prior authorization? One comment around that with the new requirements, but also an observation that the exemptions process requires a lot of investment, and there isn't always a guarantee that it'll get adopted longer term. Has there been any consideration to making adjustments to the exemptions process?
Yes, and those are, I think that's a great point, because that's a lot of what we're looking at now, right? How can we, well, I think there's been a lot of desire for the process to function better and faster and be more responsive. And the exceptions process may be one component of that and how we use that process. There are guardrails around that process right now. And so we're definitely, looking at, is there a way to use that process to better support new standards or changes, whatever it might be. And we have heard of the frustrations, I guess, or maybe the difficulty that folks have ran into in trying to use that process. So we're definitely looking at making it more user-friendly, I'll say, as well as other things. So, yep.
Great. Well, I think that covers most of the topics we've seen questions on today. So I'll turn it back to Jackie to close things up for us. And thank you again, Michael and Beth. I think it was a great presentation, and I know it'll be nice to have this, we share the webinars with attendees, the link, so it'll be great for folks to use as a resource for time to come when looking to learn more about these processes.
Yeah, and thank you again for having us.
Thank you both for joining us. Right before we leave, I just want to leave you with a few messages and call to action. So if you are interested in becoming a core participant and getting involved in the development of operating rules, please feel free to email us. It's core@caqh.org. And we'll also be giving a webinar on August 15th at 2 p.m. Eastern to learn more about the operating rules that were recommended by NCVHS to HHS. So Erin gave a brief overview of that in the beginning, but we are dedicating a full webinar to that in just a couple of weeks, and you can register using the link if you download the slides or take a look at them after we email them out in a day or two. So thank you again so much for joining us, Michael and Beth, and thank you everyone for attending today's session. We'll see you all soon.